Hi, I'm Julia Haller. I'm the ophthalmologist in chief at Wills Eye Hospital. And I'm coming to you today from the Wills Eye Alumni Society media room here on Walnut Street with some of my colleagues on the Wills faculty. This is a collaboration with Medscape Ophthalmology. 2015 has been a very exciting year in our field, and all of us are recently back from Las Vegas and the annual meeting of the American Academy of Ophthalmology. We're all assembled here to pick each other's brains about our most exciting, interesting insights gleaned out in Las Vegas and this is all from the meeting in Las Vegas. And I'd like to start off with Libba Apple, who directs our diagnostic center. Libba, what was on your radar screen out in Las Vegas?
I think the very exciting things that I saw in Las Vegas were OCT, optical coherence tomography, combined with an angiography that does not need a dye injection, which is amazing to be able to see all the vessels in the different layers of the eye that are normal, as well as abnormal vessels growing where they shouldn't be and being able to detect them. I thought that was just amazing, and I can't wait to get my hands on it. And
Carol's already got her hands on it. Carol, how are you all
know.
using that up on the 14th floor?
Sure. Well, as Libba said, OCT angiography has really gripped all of us. Standard fluorescein angiography only images one level of the vascular tree in the retina, whereas OCTA images all three levels, the radial peripapillary capillary level and the superficial and deep plexus. And in oncology, we use it every day. It helps us to image ischemia after radiation, or if patients have chemotherapy and have had some insult to the retina, we can image it with OCTA, and patients never see an injection, dye, it's very clean.
No nausea, no dye reactions.
Yes, but I have to say, I mean, when you're imaging them, it really requires cooperation. I consider myself a cooperative person, but my OCTA was not perfect.
Well, I think that the improvements in eye tracking are really the key to getting good images, and I think that the machines are just going to improve and improve as time goes on.
And you're probably
It's very
seeing that in
exciting.
other machines too.
Oh, we
just
certainly
regular
are.
OCT.
Absolutely, absolutely.
Weren't you saying, Mark Moster from our neuro-ophthalmology service was commenting earlier a little bit about OCTA in neuro-ops?
Well, I think OCTA is going to have a huge role in neuro-ophthalmology. So far, there have been some studies on MS and showing correlation with visual loss, but I think it's going to be extremely helpful in vascular disease. We in neuro-ophthalmology don't often do fluorescein angiography, but it's often been helpful in distinguishing giant cell arteritis from non-arteritic ischemic optic neuropathy. And I think the OCTA is going to be very helpful in terms of mechanism of visual loss from vascular disease. It's going to be helpful in inflammatory diseases, in neurodegenerative diseases, as well as the other techniques with OCT, such as multicolor and segmentation of the retinal layers. We're going to be able to find out mechanisms of many of our diseases that we deal with, as well as be able to detect things and treat them more efficiently.
We've got Marlene Moster here from our glaucoma service. What was hot in glaucoma, Marlene?
Well, if you really want to continue on the theme of imaging, one thing that was great through 2015 actually has to do with imaging the macula. In glaucoma, we often see structural changes before functional changes, and this gives us an extra layer of depth, so we can actually image the ganglion cell layer, perhaps even the inner plexiform layer at the same time, looking at the thickness of the retina and giving us a clue as to whether or not early glaucoma is causing this thickness layer to change. When it becomes thinner, we're more apt to treat, and therefore we're more apt to prevent disease progression. And therefore, it's really been a useful tool, and I think everyone throughout the country is now focusing not only on the optic nerve, but looking at the ganglion cell complex to aid us in our treatment of early disease.
So like you used to use cup disc ratio, pressures, and now you add in this extra factor of ganglion cell appearance, or is it the appearance of the cells or the roundness of the cells, or what happens?
You know, we don't really have the ability as yet to look at the cells individually. What we're looking at is the thickness of the layer. And when glaucoma is present, this layer deteriorates faster than just about any place else. So we're able to
Uniformly in the macula?
Well, no, segmentally in the
Okay.
macula. So we could see things changing early,
Like a nerve fiber
layer
defect.
defect,
Yeah.
and we're following this over time. So if in 6 months this area with a good scan and reliability becomes thinner and the pressure is not as we would like, we're much more apt to treat.
So just pursuing treatment very quickly, because I know this was kind of a hot topic. Minimally invasive glaucoma surgery, where do you see that on the
This
screen?
is a huge explosion in the glaucoma world because not everyone needs a trabeculectomy or a tube, and cataract surgery is so prevalent. So now we, according to the FDA, we are allowed to use an eye stent in the time of cataract surgery, which actually lowers the pressure without much risk. But coming down the pike are many, many different devices, both in the angle, in the suprachoroidal space, and will replace trabeculectomies, both from the internal approach and the external approach, to increase the safety of the procedure and make us more apt to treat surgically because the patients do much, much better without complications.
With the downside risk being lower?
Yeah, but what are the downside risks of MIGS? I mean, if
Well-
you have a short stent, isn't it more likely to get infected?
You know, no. It's unlikely to get infected. Most of the procedures are all internal. So unlike a trabeculectomy where you have erosion of the conjunctiva that may leak or become infected or have other serious complications, all of these are self-limited by and large, and therefore the risk overall is much less. There's very little to date that has been negative in the MIGS arena, which is wonderful.
Yeah, great. Mark, you had mentioned earlier, I guess all of us are involved in thinking about genes a lot more than we used to. What did you think was hot in the genetics arena?
Well, I think one of the most devastating diseases to young people visually is Leber's hereditary optic neuropathy, which sequentially causes people to lose vision in one eye and the other very rapidly, and causes blindness in young, healthy people, more men than women. And one of the exciting things that was described at the AAO was the safety the safety study of phase 1 and 2 of the genetic material being injected intravitreally into the eye. And what's really exciting about it is this leads the way to a phase 3 study that's about to start. And we at Wills are going to be one of the 3 centers in the United States that will be, with your help, injecting intravitreally this genetic material to try to help and see whether we can postpone or prevent further visual loss and or get any visual recovery in patients with Leber's hereditary optic neuropathy. So I think it's extremely exciting that we will be doing this and that it was just reported at the AAO to be safe.
Really exciting. At
exciting.
Retina Subspecialty Day, we had some follow-up information on the Leber's amaurosis gene therapy data too. So it's amazing that we really are on the threshold of offering patients gene therapy.
Right.
That may be big in oncology too, I guess.
Well, I mean,
Carol?
currently we use genetic evaluation for retinoblastoma and for melanoma for prognostication. There has been gene therapy attempted in the past for retinoblastoma. I do foresee in the future that's the way to go. Especially, if we can catheterize into the ophthalmic artery and somehow inject the material that is missing on chromosome 13, you can imagine how it might be able to repair
That'd be amazing.
a child who might have retinoblastoma.
Very, very cool.
Amazing.
Also in the retina arena, there was a lot of interest in super small gauge, talk about minimally invasive, 27 gauge vitrectomy surgery. That was a hot topic in our field. It was an interesting academy, and I think we're all recovering now. Looking forward to 2016. Thank you all so much. It was great to have our Wills faculty here to discuss with you some of our thoughts about recent events in ophthalmology, specifically at the Academy. This has been a collaborative effort between Wills Eye Hospital and Medscape Ophthalmology. Thank you.
Thank you.